Hello viewers, you are most welcome to this session where we have Dr. Mutaawe to take us through his experiences during the Ebola response. My name is Angela Chisache. I'm a scientific writer with the African Field Epidemic Network, and I'll be moderating this session. Dr. Mutaawe, you are most welcome. So just to give a background, this is one of the sessions that we are airing to commemorate the World Field Epidemic Day, which is celebrated on the 7th of September every year. And the theme for this year is collaboration is essential to field epidemiology. So Dr. Mutaawe here is going to take us through his experiences as an epidemiologist while he was in Liberia during the Ebola response. Dr. Mutaawe, you are most welcome. Please introduce yourself to our audience.
Thank you very much, Angela, and thank you very much, our viewers. My name is Mutaawe, graduate field epidemiologist, former alumni of the FET program, based at School of Public Health in Makerere, Uganda, medical doctor by training, former senior medical officer and district health officer in Kalongo. Currently, I'm working with the emergency program of the World Health Organization, based in Somalia and the Horn of Africa, as an epidemiologist for emerging and re-emerging infectious diseases. Thank you very much.
Thank you, Dr. Mutaawe. So, based on our theme, Dr. Mutaawe, which I said, collaboration is essential to field epidemiology, the theme for this year. Kindly take us through your experiences during the response in Liberia and how collaboration was critical for you to manage what you did there, the contact tracing, the surveillance, all that you went through to manage the response.
Well, allow me to give you a preamble of the setup in Liberia, probably to give our viewers a clear picture of the context into which the Field Epidemic program supported the response. Liberia is a country in West Africa with a population of 4.1 million people. It is decentralized from national to county to district to communities. The country has had a history of war. Most of the people live in IDP camps in the capital Monrovia, and others live in neighboring countries. So the long decade of war led to weakening of the health system in Liberia across all systems of the health system as we know them. So Ebola found a fertile ground to spread from one region to one area to another. The outbreak of Ebola in West Africa started in a district at the border of the three countries around about December 2013. That was at the border of Guinea, Sierra Leone, and Liberia. Round about December, it was their Christmas present. And it was a child who died. People came together for burial. We shall discuss how these people managed the day. Then, as you know, for us in Africa, you travel from the remotest area to go and bury. We have relatives in the city. They travel to go to the villages to bury. So after the burial, people went back from wherever they came from, and the outbreak spread. In Liberia, the border district that first reported the case is called Lofa. It is bordering Guinea, at the same time bordering Sierra Leone, and they detected those cases in March. Official reporting. So in Guinea, I would like you to note the timeline. In Guinea, they got to know about this case in December. Liberia, they get to know about this case in March. And March, by the time it got to the capital is 600 kilometers away from Lofa. Actually, to put it in context, it's a day-long drive. So the cases that had been detected in Lofa are moved from that long distance to the capital Monrovia. And by April of 2014, the cases had increased. So when the cases increased, it became so difficult for the country to cope. So that's why it became a public health event of international concern. Now, when the government of Liberia, Sierra Leone, and Guinea, the three governments got overwhelmed, they requested the African Union for support. The African Union mobilized member countries, and they established a department called ASEWOA, which was headed by Uganda and Keta, and they mobilized, first they were the field epidemiologists from the different African countries, including Uganda, Zimbabwe, Kenya, Tanzania. I was the delegate from Uganda because I had participated in Ebola response under AFENAIT in 2009 in Kira. So having that experience, I was chosen to be part of the team to go and support Liberia in the Ebola response. As an epidemiologist from AFENAIT, our field of expertise at the time was in the field of disease surveillance, which involved data collection, analysis, and dissemination. And for Ebola, every case you have to look at the contacts. So, and to respond effectively, we had to work with other agencies, both local and national, which had capacities in different fields of response. The World Health Organization came in handy for case management, MSF for case management. We had organizations like UNICEF for WASH and risk communication. So, for the response to be effective, the AFENAIT team had to collaborate effectively because the cases detected in the communities were supposed to be handed over to the case management unit. So, effective collaboration is very important because you have to work with different stakeholders for you to mount an effective response. Thank you.
Thank you so much. So, can you take us through the surveillance? How did you manage to do all the surveillance with all the strengths that you went to? How important were the other collaborators in helping you do the surveillance effectively?
Well, one of the reasons as to why it took very long for the Ebola to be detected was because of the weak surveillance systems in Liberia at the time, which had been weakened by a long decade of war. There were no human resources to mount an effective surveillance system. The country is quite diverse, the populations are sparse. So we had to look at other ways in which surveillance had to be done, especially detecting cases from the remotest as quickly as possible. This one, we established community health workers in all those areas, and those community key points would tell us notification of deaths, any person who died, and the communities themselves would tell us who was sick with fever. And in each of the counties, the 15 counties, and at national level, we established a technical response unit, which had a 24/7 hour toll-free line. And all these alerts would come in from the communities to the call center. And at the call center, they would be registered, triaged, and we had to send rapid response teams from the nearest response point to where the alert was coming from. And what we did different for us to mount an effective surveillance system as AFENAIT, we decentralized the response. Instead of coordinating everything in Monrovia at the center, we spread ourselves. That's why I ended up in Bong County, one of the most affected regions. So there, we effectively set up a coordination center which received the alerts from the communities through our community health volunteers. And we established rapid response teams who would go to investigate those cases and follow up the contacts. Every time we received an alert and we were to send a team, our focal point was always the leader of that community, supported by the catchment health facility. So later in the response, we even brought the traditional healers on board because we noted that the Liberians and many people affected with Ebola thought that it was witchcraft, and they were seeking care among traditional healers. So we made it a point that the traditional healers were also our surveillance officers in that community. So who would refer to us? Those cases. Again, in the communities, we identified funeral homes, because many of the funeral homes, the Liberians keep bodies waiting for an appropriate time to respond. So, and the more you keep the Ebola body, is the more. So these funeral homes, again, those people were brought on board to be our contact point to send us alerts. So we looked at all the social services in a particular community, and any point of contact where we expected those cases to be transported became our contact points. I remember in one of the towns in Bong town called Taylor, even the border men, their lead, we requested him to be our, because these are the people who transported the sick from homes. So we developed SIPO tools, which the community would use to fill in data electronically using their mobile phones. Because at one time it became very difficult to follow up the contacts for all the. So we gave them even the kits to measure the temperature, they would record themselves. For us, we keep them electronically and give them some support. So we adopted quite a number of measures using both electronic and paper-based, even informal methods to get all this information. Which information was analyzed, and we also made sure that every morning we would come up with an information session, which was always aired live on different radio stations in Bong County where it was stationed, because the people had to know the information coming and what to do so to avoid panic and pandemonium. So we engaged these communities effectively so that they even became our champions. For instance, if somebody came from village X to visit them, they would not accept them unless they had a medical certificate of clearance. Because when the Ebola was in Monrovia, the cases spread, they increased. And people started running back to their villages because there were no services in the center. So in going back to the villages, they spread the outbreak further. So specifically in surveillance, we use different avenues to collect this data right from the communities up to the center. So we collected this data, analyzed it, and sent it back for decision making. Yes.
So we see that it's clearly coming out that the community engagement was very critical in managing this response. What other strategies, what do you think were the most critical strategies that you used for the community to build trust?
Well, I remember in July when they established a curfew in Monrovia when the cases were increasing. As the FETP team under Sewowa, we requested the president of Liberia, Madam Salif, based on the experiences of the leadership in Uganda in the fight against HIV, to establish a presidential task force, of which was the chair, to be the leader of the response for Ebola in Liberia, which she took up and was very effective. Also, the religious leaders were brought on board, as well as the traditional leaders, because we noted that almost 80% of the Liberians believe in traditional medicine. So the president, being at the center, she commanded authority, she commanded respect, and you could imagine hundreds of NGOs working with no direction. Even our work as FETP in surveillance would not be effective. But when the president strengthened that kind of collaboration and coordination and leadership, things began falling in place. Yes. So the other, what we did, with time we were overwhelmed, and through the African Union, different countries started sending medical workers to supplement what we had been doing, because we had very many gaps in, say, managing barriers, the safe and dignified barriers, We had very many challenges in, again, effective contact tracing. So with support through the African Union, we got additional health workers from Kenya. We got additional health workers from Nigeria who came to host the work that we are doing. At the same time, we did a crash training program for the health workers to be able to give them skills in surveillance. Most of the trainings in Africa at the time were basically clinically oriented, with a limited emphasis on epidemic management. So Ebola gave us an opportunity to train on job the health workers, which would later translated into the frontline FETP in Liberia and other countries.
So, given your experience still in Liberia and basically where you're stationed, we see that you learned a lot from there and a lot was done from there. So moving forward, we know that a lot is coming out. We are getting quite a number of outbreaks. Recently we had the COVID outbreak. We have the monkeypox outbreak that is becoming a public health threat. What lessons do you have for future epidemics, especially regarding collaboration to manage those outbreaks? What is the takeaway for field epidemiologists in management of the upcoming epidemics?
Well, thank you, Angela. In our planning these days globally, we always put disease X because we are just into the next epidemic, so I should say. We do not know when the next epidemic will come. So every epidemic gives us an opportunity to improve for the better. When we were in Liberia, there was no capacity whatsoever to do laboratory testing for Ebola. Actually, we could hardly test more than 10% of the samples. But because of the capacity building and investment, by the time the outbreak was over in December, almost all major hospitals had capacity for PCR and rapid diagnostic kits. Again, the capacity building in country, because it's difficult finding teams of experts from different places, ship them to another African country, challenges of logistics, travel restrictions and whatnot. So capacity building in country, based on the resources they have, based on the HR they have, is always very important and sustainable, because these people stay in the system and be able to detect and respond. Then community empowerment. Most of the time, the communities always get to know these alerts and they always keep quiet, and surprisingly they have their own mechanisms of coping. So the community involvement and empowerment is also very key in managing these epidemics. Then sustained interventions across all technical areas. Not these knee-jerk reactions that, hey, we have Ebola, let's do it, go. These response activities and priorities have to be sustained. When we were in Liberia, we did a projection which turned out to be false. We are expecting over 1 million cases of Ebola. Imagine an IDP camp with 1 million people or more. There is an Ebola, there are Ebola cases. People have died in hospital. People have come and stolen bodies from there. They've stolen the mattresses. So basically they've amplified. Another very interesting story. On Somali Drive in Monrovia, there is a very strong Muslim clerical life. And in Liberia, once you die, their burial exercises are exaggerated. They sprinkle the mourners with the waste of the body so that they believe it gives them, you become like the dead. People even take that waste back home. So there are so many social behaviors that are supposed to be improved for effective epidemic leadership. Then coordination. We have said that traveling from Uganda to China takes 6 hours. And from China to any part of the world, because China is basically. So with the improvement in travel, these populations growing up and cities coming up, so it is very easy for an epidemic to travel from one area to another. So the response and preparedness has to be sector-wide, including all, not only animal health, we need people at the airports, we need the army. Actually, that's when we noted during the East Coast that the armies in many of these African countries have a better capacity to even transport logistics where you cannot go. So you have to bring everybody on board based on their capacities to be able to mount an effective leadership. Then the other is research and development. There are so many things you have to research on as you're responding to. When we had just arrived, we were the first people as AFNH to do dead body swabbing. To see, because even if somebody died of an accident, it was misclassified as Ebola. So for us to be clear, we came up with a strategy of swabbing dead bodies. To see, there was a test kit that had come from America as a pilot. And we only found out that 30% of the cases that were being reported as Ebola were actually Ebola. You see? Yes, because it was Ebola presents with many signs and symptoms. There was this misnomer that for as long as somebody bleeds, it's Ebola. So even everybody who got any simple bleed from any other cause was classified as Ebola. And because the health system had basically shut down, people died of different ailments because the health system had collapsed, had shut down to respond to Ebola. So for many of those deaths, they had been. You see.
Thank you for sharing all that, Mutaawe. So regarding global health governance, what changes are needed in global health governance to ensure that moving forward, the effective responses are in place for future epidemics and outbreaks that are anticipated?
Well, global health governance comes with quite a number of challenges because different countries have different norms and have different regulations. Unfortunately, even the international health regulations are not legally binding. It is just a buy-in of different countries. The country may conceal this information, like we are seeing as happened in COVID-19. The same also happened in Ebola. Countries got to know the Ebola and the information was not effective. So the countries have to come together and strengthen the implementation of the international health regulations. And they become more binding than they are now. Then the other issue is the capacities, especially in complex emergencies. The first samples to conduct Ebola testing were sent to Rui Pasteur Institute. There are so many barriers of exporting samples, say from country X to country Y, because these are infectious agents. So those are the things that these countries have to look at that level to break these barriers. Again, when you look at in Africa, you see a lot of improvement. You need basically visas to get to many of these countries as an African. If you don't have a UNLP, if you don't have an African Union passport, getting to country X minus this within our region is becoming very difficult. It's difficult. But with political federations like the AU, like the ECOWAS, like the East African Community, I can see all these barriers being broken. Because actually, these barriers are only geographical. In Liberia, you would see boys going to dance across the border in Guinea. So to give you a better scenario, where we are staying here in Okoto, across this road is Liberia, the other side is Sierra Leone, but across the other church it's Guinea. But in this, that town is called Foya. So you can be in 3 different countries basically at the same time. So the people mix freely. They have Liberian has a garden in Liberia. After finishing the gardening, he goes to have a drink in the neighborhood which is in Guinea. So all these the communities are not separated by these borders. These borders are only geographical and imaginary. So these countries have to work together to make sure that those borders do not impede all these resource activities.
So thank you, Dr. Mutaawe. Is there anything else that you want to share with our audience regarding how collaboration is essential to field epidemiology, given your experience in Liberia and even where you are right now at the WHO?
Well, thank you very much. Our dear viewers and listeners, we cannot overstate the importance of coordination and collaboration. When we are still fellows in field epidemiology, this was always the key message, that you're going there alone, make sure you collaborate with the people you find in the field, both the local communities, the local authorities, and the partners you find, because no organization is a standalone, having capacities and processes. So you have to do a stakeholder analysis, understand which organization has which capacity, which you can leverage on to make sure that you protect the communities from the emergency. The leading vision is you're serving the community. You're serving the community to prevent that outbreak and to control its spread. So you have to use all resources at your disposal within the organization and outside the organization. Because at the end of the day in epidemiology or epidemics, the question they always ask, is the outbreak over? Yeah. So it is only after the outbreak is over that everybody will clap. After you have brought everybody on board. Thank you.
Thank you so much, Dr. Mutaawe, our viewers. Thank you for staying with us. And Dr. Mutaawe, we really thank you for making time to come to speak to us about your experiences in Liberia and about future epidemics moving forward. So, like we said, please look out for more of our episodes from the African Field Epidemiology Network as we commemorate the World Field Epidemiology Day 2024 on the 7th of September. Thank you for watching.